Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is polio. This slide shows an electron micrograph of the poliovirus. So, as of April 2024, Pakistan and Afghanistan are the only countries with endemic polio transmission, although recently in Gaza there have been reports of further cases, hence the need for mass vaccination. There's been a drastic reduction in global cases since the introduction of vaccination programs. Risk factors, however, for outbreaks are poor sanitation, low vaccination coverage, and war or conflict zones, as we have recently seen. Polio is an enterovirus from the Picornaviridae family. It primarily affects the nervous system, leading to poliomyelitis. The transmission is feco-oral and it's highly contagious. Poliovirus is a non-enveloped, positive-sense, single-stranded RNA virus. And poliomyelitis itself is a paralytic disease, but most infections are asymptomatic or mild. Entry is via ingestion of contaminated food or water, and initial replication occurs in the oropharynx and intestines. The virus enters the bloodstream, and then most cases do resolve here. In about 1% of cases, the virus crosses the blood-brain barrier, infecting motor neurons in the anterior horn of the spinal cord, leading to paralysis. There are 3 serotypes of the poliovirus: PV1, PV2, and PV3. PV1 is the most frequently associated with outbreaks and paralysis, while PV2 and 3 were declared eradicated. Immunity to one serotype does not confer immunity to the others, crucially. There are various clinical features associated with poliovirus infection. 72 to 90% are asymptomatic, and most infections are subclinical. About 4 to 8% cause a minor illness, and these present with aspects such as fever, sore throat, gastrointestinal upset, and lasts 2 to 5 days. Non-paralytic poliomyelitis, seen in 1 to 5% of cases, is an aseptic meningitis with headache, neck stiffness, and photophobia. And finally, in less than 1% of cases, you may see paralytic poliomyelitis. And this comprises acute flaccid paralysis affecting the limbs in an asymmetrical manner and more predominantly affecting the lower limbs. It can be temporary or permanent. And finally, post-polio syndrome occurs decades after recovery with muscle weakness, fatigue, and joint pain. So as you can see, there are various different ways in which the poliovirus may present, either during illness or afterwards. Diagnosis is based on clinical suspicion based on history and physical exam. Lab confirmation is done using viral culture from throat swabs, stool samples, or CSF. Reverse transcription PCR detects the poliovirus RNA. We can also detect rising titers of anti-polio antibodies. CSF analysis will show lymphocytic pleocytosis, an elevated protein level, normal glucose in cases of non-paralytic and paralytic poliomyelitis. Most cases can be managed with supportive care. Mechanical ventilation may be required for respiratory muscle paralysis, and physical therapy is recommended to prevent contractures and promote function in paralyzed limbs. There's no antiviral treatment available. Management of complications may be required, such as prevention of secondary infections and long-term rehabilitation for paralytic cases. There is a polio vaccination, as we've discussed, so you can have the inactivated poliovirus vaccine, IPV, which is intramuscular, or the oral poliovirus vaccine, OPV, which is a live attenuated form. The Global Polio Eradication Initiative, or GPEI, began in 1988 and led to the eradication of PV2 and PV3. So now let's do a question. A 32-year-old woman presents with progressive weakness in her lower limbs, which started a week after she recovered from a flu-like illness. She has a history of poliomyelitis as a child, which affected her left leg. On examination, there is new muscle weakness in her previously unaffected right leg. Her respiratory function is normal and there are no signs of sensory loss. What is the most likely explanation for her current symptoms? So our options are Guillain-Barré syndrome, post-polio syndrome, recurrent poliovirus infection, myasthenia gravis, or peripheral neuropathy. Now, from what we've discussed, this presentation classically fits with post-polio syndrome, particularly when we can see that she has a history of poliomyelitis as a child. And this can happen many years later. Post-polio syndrome does not necessarily occur in the months or even years after the infection. So in this case, B is the correct answer.
Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.